Hello, dear friends. How are you? Happy to be here again. This is Leila Mostafi, founder of Lillie Excellence Center, and I am international midwifery and OB/GYN trainer with more than 15 years experience in training and managing different clinics and medical team in different countries. Today, I'm going to talk about vulvovaginitis. I hope previous class was effective and helpful for you guys. So today I'm trying to make a brief description about vulvovaginitis. I will try to share in between for you guys to make your training more easily and more understanding. Okay. Okay. So let's start. Today I will talk about practical guide to diagnosing and treating vaginitis. First, I will talk about physical exam. Then I will go to concept of bacterial vaginosis. Next coming class, I will talk about Trichomonas vaginalis. And the other class, I will talk about candidiasis. Okay, so let's have a small introduction about our different type of vaginosis. As you all know, we have different type of vaginosis. So let me share this desktop, my PowerPoint with you. I have a very beautiful picture. There is one animation that I like it so much. Yes, as you see, there is bacterial vaginosis. Here you will see there are symptoms like elevated pH and do not smell that what so. You will find some clue cells here that caused by Gardnerella vaginalis. And I love this comic because it's bring very beautiful comic pictures. And here there is candidiasis. Candidiasis, it is the conditions that promote Candida albicans infection include systematic antibiotics, coming by systemic antibiotics, diabetes, pregnancy, and birth control pills. As you see, this is the normal pH, and you will see the yeast, baths, and pseudohyph is available here. But in trichomonasis, as you see, there is some motile pear-shaped flagellated trichomonasis. This beautiful shape of trichomonasis. As you see, this is a motile, and there are, look, pear, yes, and flagellated trichomonasis. You will see here, elevated pH is available. pH is elevating. As you see, there is the strawberry cervix. Sorry. So, when you see this strawberry cervix, you will go for help. But in physical exam, using a good light source and a vaginal speculum, inspect the vulva, vaginal valves, and cervix for the presence of lesion. You can find lesions or presence of erythema or excoriations. The discharge should be observed for color, consistency, odor, and whether it is vaginal or examined from the cervix. Using either a dipstick or paper roll, measure the pH of secretions from the vaginal side wall, not from the posterior fornix, which may be contaminated with cervical mucus. Then, separate slides of the discharge should then be made with 10% KOH, potassium hydroxide, and with normal saline. Then, secured with cover slip and examined for flagellated protozoa, hive, or Bacterial or other organisms under the microscopic. Slides should be waved for the release of volatile, a fishy or musty odor. Upon adding the alkaline KOH solution, since this is a sign of bacterial vaginosis. As you see, this is the candidiasis, and you will see the vaginitis labialis, VPH. Next picture, I want to show you how to diagnose. As you see, there is some clinical sign. In clinical sign, you will see some vulvar pruritus indicating a spread of fungus distally onto the vulva, hyperemic vagina, erythematous or excoriated vulva. And there is some discharge characteristics. These characteristics that I show you here, I show you in this picture, this candida vulvovaginosis, the shape of the picture here you will see this discharge. Because these characteristics of discharge is very important. As you see, thick, crude white discharge or vulvar pruritus color. As you see, color is white, as you see here even. Color is white, off-white if mixed infection present consistently and curdled. Odor is not malodorous unless a mixed infection is present. In this picture, you will see vaginal mucosa can be covered with numerous white thrush-like patches in vulvovaginal candidiasis. And in this picture, you will see pseudohyph and blastoconidia or yas cells and wet amount of KOH preparation are consist with Candida albicans. You can find such these things. And both pseudohyph and blastoconidia, as you see in this place, yas cell, stain purple on grams stain preparation of clinical material from patient with candidiasis. And what about vaginal pH? It is normal range between 3.8 till 4.2. About microbiology. Microbiology, hive or budding yas visible in 50% till 70% of cases. Fungal elements on pap smear could indicate colonization, not infection. Culture can confirm and speciate yeast. In previous picture, you can see the picture of that. And about treatment for candidiasis. If you want to use OTC, over-counter intravaginal agents, it is clotrimazole 1% cream, 5 grams intravaginally daily for 7 to 14 days, or clotrimazole 2% cream, 5 grams intravaginally daily for 3 days, or you can use miconazole 2% cream, 5 grams intravaginally daily for 7 days, or miconazole 4% cream, 5 grams intravaginally daily for 3 days, or miconazole 100 milligram vaginal suppository, 1 suppository daily for 7 days. Plus, you can use miconazole 200 milligram vaginal suppository, 1 suppository for 3 days, or miconazole 1,200 milligram vaginal suppository, 1 suppository for 1 day. Or you can use teoconazole 6.5% ointment, 5 grams intravaginally in a single application. Prescription intravaginal agent will be, you can use butoconazole 2% cream single dose, bioadhesive product 5 grams intravaginally in a single application, or terconazole 0.4% cream, 5 grams intravaginally daily for 7 days, or terconazole 0.8% cream, 5 grams intravaginally daily for 3 days, or terconazole 80 milligram vaginal suppository, 1 suppository daily for 3 days, oral agent, and fluconazole 150 milligram orally in a single dose. The cream and suppositories in these regimes are oil-based and might weaken latex condoms and diagrams. Patient should refer to condom product labeling for further information. Even women who have previously received a diagnosis of VVC by a clinician are not necessarily more likely to be able to diagnose themselves. Therefore, any woman whose symptoms persist after using an over-the-counter preparation or has a recurrence of symptoms less than 2 months after treatment of VVC should be evaluated clinically and tested. Unnecessary or unapproved use of over-the-counter preparation is common and can lead to a delay in treatment of other vulvovaginitis etiologies, which can result in adverse outcome. No substantial evidence exists to support using probiotics or homeopathic medicine for treating VVC. And about follow-up. Follow-up typically is not required. However, women with persistence or recurrent symptoms after treatment should be instructed to return for follow-up visits. And about management of sex partner. Uncomplicated VVC is not usually acquired through sexual intercourse, and data do not support treatment of sex partners. A minority of male sex partners have balanitis characterized by erythromatous area on the gland of the penis in conjunction with pruritus or irritation. These men benefit from treatment with topical antifungal agents to relieve symptoms. And about diagnostic consideration. Vaginal culture or PCR can be used. albicans candida is intrinsically resistant to azoles. Therefore, culture and susceptibility testing should be considered for the patient who remain symptomatic. And if some recurrent vulvovaginitis, vaginal candidiasis happen, what we should do? For this case, more episodes of systematic VVC in less than 1 year, or Candida glabrata and other non-albicans candida species are observed in 10 till 20%. Yes, in 10 to 20% of women with recurrent VC. A longer duration of initial therapy, for example, 7 to 14 days of topical therapy, or 100 milligram or 150 milligram or 200 milligram oral dose of fluconazole every third day for a total of 3 doses. And for the person who have oral fluconazole, like 100 milligram or 150 milligram or 200 milligram dose weekly for 6 months, or topical treatment used intermittently can also be considered. So this is called recurrent vulvovaginal candidiasis. And how is severe vulvovaginal candidiasis? If a patient gets a treatment of 7 to 14 days of topical azole or 150 milligram of fluconazole in 2 sequential oral doses, second dose 72 hours after initial dose, this will call severe VVC. And about non-albicans vulvovaginal candidiasis. What is non-albicans VVC? If longer duration of therapy, about 7 to 14 days, with a non-fluconazole azole regime as an oral or topical happen. And if recurrent occurs, 600 milligram of boric acid in a gelatin capsule administered vaginally once daily for 3 weeks is indicated. Okay. And about special consideration. We should consider some special consideration. First, compromised host. Women with underlying immunodeficiency, those with poorly controlled diabetes or other immunocompromising conditions like HIV, and those receiving immunosuppression therapy like corticosteroid treatment might not respond as well to short-term therapies. Efforts to correct modifiable conditions should be made and more prolonged. For example, for 7 to 14 days, conventional treatment is necessary. And what about pregnancy? Only topical azole therapies applied for 7 days is suggested, and a single 150 milligram dose of fluconazole might be associated with spontaneous abortion. What about for HIV infection? Vaginal candida colonization rates among women with HIV infection are higher than among women with HIV with similar demographic and risk behavior characteristics. And the colonization rates correlate with increasing severity of immunosuppression. Same treatment plus one-term prophylactic therapy with fluconazole 200 milligram weekly has been effective in reducing Candida albicans colonization and symptomatic VVC. Thank you so much for listening to this presentation. I hope this training about VVC, vulvovaginal candidiasis, and bacterial vaginosis be helpful and effective for you. For the next class, I will talk about trichomonas vaginalis, and then we will talk about cervicitis. Then we will go with some case study. As you know, if you want to be more competent to write prescription and be more competent to prescribe, diagnose, and treat your clients, you have to work more on case study. Thank you so much. If you like this training, I would be thankful from you to write your comment, share, like, and subscribe to Lillie Excellence Center in YouTube. Don't forget, in YouTube, Lillie Excellence Center, just you subscribe and please do commenting. Thank you so much. Have a nice day and have a fantastic upcoming days for all of you.